I've recognized in my role as an academic for decades that if we don't communicate, we are not providing the best medicine for our patients. What teaching better communication does is allow a physician who may have excellent skills and knowledge in their field of expertise get further information about how that affects the patient experience. So I can say to you, tell me where your pain is, and you're telling me it's in your lower back. But if asking you to tell me how your pain makes you feel is a very different perspective. Because if the patient says to you, well, the problem is I'm not coping in my work, or I'm not coping at home, or I'm not sleeping, or my relationship with my spouse and family are affected because I'm angry all the time, makes it much more likely that that physician will have that aha moment to say, okay, that is different now in how I approach that patient, from just saying, look, let me give you this injection and it'll feel better. And doing simulations to throw those sort of pieces out there purposefully in a simulated patient environment gives insight to a learner as to how that patient is actually coping in a way that's much more useful from the perspective of what you're going to do next.
Nothing in medical school prepares you to deal with patients that are struggling with chronic pain or struggling with pain addictions. The existing training focuses a lot on identification of pain, management of pain and pain disorders. This simulation-based learning takes into account the other skills in medicine, often dubbed the softer skills or the communication skills, and how to build that patient trust and patient rapport. The scenarios felt very real. Not every single patient that I deal with in clinic is as difficult as these patients in the simulated encounters, but more often than not, you will get patients that come into your office that are struggling like these patients were. The consultation with the pain patient on a very high dose of opioids was a very uncomfortable and unnerving experience. I didn't like it. Initially, it was quite difficult because you know your mentors and people that you look up to are watching you. But that's a good thing. It's those things that are uncomfortable, that are unpleasant, that are going to make you grow as a physician.
This is exactly what we need to improve the quality of our trainees, so that they understand that there's so much more to what they're doing than just seeing a patient and providing an intervention or suggesting a new therapy. It's being able to bring all those different pieces of the emotional aspects of an encounter to a place where both the physician can be comfortable to say, I think I can handle that, but you also have tools to use with a patient who you may have made angry, or you may have made them feel angry, not because you've done anything, to a place where now they can leave your office and not go home and do something terrible, or not say, I'm never going back there because I've had such a negative experience. Learning about how that impacts the patient's social environment, that sort of biopsychosocial piece, is exciting, because it makes me feel that we're giving them a better rounded education, and we're also making sure that they understand, again, that patient's environment in a way that makes the care for the patient more effective.